Good evening, everybody, and welcome to the MEDTalks. My name is Joe Kostrich. I'm a GP from Perth and also on the organising committee for the GPCE. So obviously welcome along and thanks for coming out this evening. The MEDTalks Beating the Killer called Heart Failure is both live here for those of you in the room and also is being simulcast online. So welcome to all of our people out in cyberspace right around the country, and it's so great to have so many of you with us. We're going to have four talks tonight. They're all going to be short, sharp and punchy 10-minute talks on different aspects of heart failure, getting you thinking about prevention, diagnosis and treatment, and ultimately hoping this will be quite impactful and have useful information that you can use when you go back to your surgeries on Monday. Now, to start with, a couple of housekeeping things, standard stuff. Please turn your mobile phones on to silent. No flash photography in the room. And with questions, we will take questions from the floor, and we've got a couple of little tweaks to tell you about with that later. But you can also ask questions online via slido.com. So if you go to www.slido.com, and you can do that obviously for those of you who are online, but those in the room who prefer not to put your hand up and want to go onto your devices, you can do that. You go to slido.com, you then enter the hashtags MEDTalks, capital M, capital E, capital D, talks with a capital T, and put in your questions. And we'll be taking questions from the Slido later, the miracles of technology. All right, to get us started, we're going to have Associate Professor Gary Kilov deliver the first speech. Gary is a GP educator and consultant and a founding member of the RACGP Diabetes-Specific Interest Group and a co-founder of the Primary Care Diabetes Society of Australia. Gary's been published in a number of peer-reviewed journals and is obviously a practising GP in Launceston, Tasmania. Gary's talk this evening, Current State of Heart Failure Management in Australia. Please welcome Gary Kilov.
Thank you, Joe, and welcome everybody. What I'm going to do is really set the scene to, I guess, reintroduce you to heart failure and maybe introduce some statistics, some insights, some perspective that you may not have. So to my mind, heart failure has been a little bit of a Cinderella condition as far as major adverse cardiovascular events are concerned. We often see myocardial infarction, cardiovascular death as primary endpoints in studies. We don't tend to see a lot about heart failure. And imagine, if you will, either yourselves or your patients fronting up at an emergency department with crushing central chest pain radiating up to the jaw and down the arm. And you know what happens? Doors open. There's action. There's no dilly-dallying. You're not going to be loitering around the waiting room or the vending machine. Stuff happens quickly. The same would apply, for example, if you presented with an evolving hemiparesis. But if you were presenting with an insidious and progressive breathlessness, fatigue, a bit of weight gain, perhaps associated with some swelling of the ankles, you may be more likely to get a letter to go back to your GP rather than have anything proactive being done. And what I'm going to suggest is that maybe this Cinderella deserves a whole lot more respect and a whole lot more attention than we've been giving it. But I want you to forget about the Cinderella that we all know and love, that gentle, soft-spoken underdog. This is a Cinderella from a parallel universe. She's nasty. She hurts. And I'll show you what I mean. We'll just share some statistics with you. So, heart failure is a common condition, affects about 1.5% of Australian population. Around 80 new diagnoses every day, which equates to about 30,000 new cases every year. And patients are sick. There are 50,000 admissions every year for heart failure. And as with many of our chronic conditions, this is a burden largely carried by our older population. So how well do people do with heart failure? How nasty is this condition? Well, if we look at a 3-year prognosis for people with New York Heart Association Class 1 and 2, so these are people who we would generally consider at the milder end of the spectrum, 1/3 do not survive 3 years. If we look at the more severe end of the spectrum, Class 3 and 4, 4 out of 10 won't make it for 3 years. If we contrast this, just to get a bit of perspective, I guess, with breast cancer, overall 5-year survival for breast cancer is over 90%. Now, if you go through a thought experiment with your patients, with your female patients, and pose the question, which of these diagnoses would you fear more? I'm prepared to wager that a significant portion would fear breast cancer more than they would heart failure. This condition is not well known, it's not well understood, certainly by the general public, but I think sometimes we ourselves in general practice sometimes don't accord it the respect that it deserves. 20% of patients who've been admitted to hospital will be back in hospital within 30 days. If you stretch that out to 50 days, to 6 months, I beg your pardon, it'll be 50%. So there's significant healthcare utilisation, significant morbidity associated with this condition. And the impact, not surprisingly, is on quality of life, as well as quantity of life, as I've shown you. So 2/3 of patients with heart failure will complain of symptoms, or will, certainly on asking, will admit to symptoms associated with mood disorders such as depression, anxiety, not surprisingly, when the impact is so significant in their lives. And there's a loss of function that is associated with social withdrawal. People become socially disengaged because even daily activities of living, things that are not challenging, that we take for granted, are often a significant struggle. And this not only impacts on the individuals themselves, but of course their carers too. And the majority, over 60%, report difficulties with recreational activities, pastimes, sports, hobbies. These are the things that make life pleasurable. These are the things that we enjoy. And having to give these up impacts significantly on your quality of life. So how well do we manage it? How well are we addressing this condition that really deserves significant attention? In this New South Wales Hospital heart failure audit, so essentially we're looking at care in tertiary institutions. About 60% were on an agent that blocks the angiotensin-renin system. 60% were on beta blockers. A quarter were on mineralocorticoid antagonists. And 1 in 2 were referred for cardiac rehab. Now, if you think that all of these agents are well recognised, well accepted as improving outcomes, as improving survival, we've had these modalities for a couple of decades now. These are not new, and all of these are easily within our reach in general practice. This is standard basic care. And you can see that even in tertiary institutions, perhaps there's room for improvement. Now, it's not to say that every person, we wouldn't expect 100% of patients to be on all of these agents, but I suspect that there are a number who should be, who are not. So I know it's been a bit of a doom and gloom introduction, but I'd like to end on a positive note. So what can we do? What can we do, as Joe said, on Monday? Is there something we can do to make this better? So the first thing we can do is do what we're already doing, but do it better. Make sure that our patients are on optimal care. Make sure that we have a high index of suspicion. That perhaps that smoker who's breathless, who we diagnose with COPD, maybe there's something else going on. Maybe we need to investigate more aggressively and more proactively. So the agents we have already are not bad. They have evidence behind them in terms of prolonging life and improving outcomes, but they're new agents, some that are recently become available, and our expert speakers will tell you about what's coming, what the future holds. So it is positive, it is bright, but it depends on us to ensure that we diagnose the condition in the first instance and institute the treatment and investigations. The one person that I haven't spoken about, at least directly, is the patient. Now, you've heard about the burden of disease. You're going to hear from medical specialists, but the person you really need to listen to most is the person who's suffering from the condition. And thankfully, we have somebody who will tell you what it's like to live with a condition. Thank you.
Right, thanks very much, Gary. And it's an interesting reflection that, yes, if we ask people what would you rather have, a form of cancer where you've got a 90% 5-year survival or something where there's 30 to 40% people are going to be dying in 3 years. It's really interesting statistics, and these conditions that develop slowly, often we don't give as much precedence to. Now, if there are questions, we're going to take them at the end, but you can be entering them now on slido.com with the hashtag. But as I say, we'll take all questions at the end. Our second presenter this evening is Associate Professor Ralph Autumn, who's a GP and Honorary Clinical Associate Professor right here in Melbourne at the University of Melbourne, and he has numerous memberships of boards, expert panels and working parties. But in addition, Ralph has brought along a guest, Trevor Duncan, who, as Gary alluded to, will talk about the patient perspective, and he is a person who's actually lived with heart failure. So could you please welcome Ralph and Trevor?
Well, thanks, Trev, for coming along. I'll just, a bit of an introduction. So Trevor was diagnosed with a cardiomyopathy, and we actually think it's been since 2005, not 2007. But and you can see that's where his blood pressure has been sitting. His weight has been, has fluctuated a little bit, but in fact, I'm a little bit happy with that weight gain because where he came from a while back wasn't so much with fluid, but he'd lost a huge amount of weight because he was so unwell. And this is what his history includes. And you can see the range of medications that he's on. So my first question, Trevor, you've just heard our previous speaker paint a really bleak picture about heart failure. I mean, what did you think of that?
I tend to disagree with it, actually, because I think it's a person in themselves, their attitude. And I think if you're going to sit in the corner and feel sorry for yourself, well, go and put a gun to your head. It's, attitude is everything in this, and if you don't fight it, if you don't get up and, I can't become a couch potato. So, and you've known me for a long time, yes. I won't rest like that.
But, at that time you were diagnosed in 2005, I mean, there was a huge change in life. I mean, what did it mean for you being diagnosed?
It just meant that I had to slow down in life. I couldn't do what I used to do. I was a builder, and I couldn't build a house anymore. I had to just take more time to build it. But everything cuts down in half even more. As I was washing the car yesterday, I had to wash the front half first, go and have a rest, come back into the second half, but I won't let it beat me. So, and you just keep on doing what you can when you can.
I mean, certainly it's a great attitude, but you're also a keen welder at one stage. I mean, what's happened to all your welding and stuff?
Well, no. If I walk near a welder with this, it goes. It either gets turned off or it goes off.
Right. So Trevor
I think I'd prefer it to go turned off.
So Trevor has an implantable cardiac defibrillator, and it's actually gone off 12 times.
Yeah, about 12. Yeah, so, lost count.
So that's saved your life, 12 times
yes,
or more?
Yes.
What does it feel like when it goes off?
You've been kicked by a horse? It feels like, it's like a bomb going off inside you. Everything sort of explodes out. Even my head seems to swell up. It's just very, very hard to explain. But after the shock that goes through you, which is 832 volts in the centre of the heart, within 5 to 10 minutes, I'm back into a sinus rhythm, I think, instead of the AF. So I do feel better. So I sort of look back on and sort of say things, sort of.
Well, you're still here, so that's really good.
Well, that's true.
Now, there was a time when you were newly diagnosed. You went along to a cardiologist to talk about that diagnosis, and the way he talked to you really knocked you and your partner for six. What happened?
I just come back from the Alfred with reasonably good news. I sat down in his office and he spoke to me like a piece of dirt and just spoke to my wife like that. And I thought, I don't need this crap in my life. I just stood up and said, see you later.
He phrased something to you about, you're saying, well,
told
what
me I was
can
going
be
to die.
Yes.
Yeah.
And there was nothing he could do for
I
you.
should go back there tomorrow because I'm still here.
So, but that had a profound effect on Sue, your wife. I mean,
Yeah, it's just, I had to get her through that because she was really worried. But like everything, we fought through it and got through it, and got on with life.
so, and the impact on her after that, the visit at the doctor's surgery, what, she was crying all the way home because she thought that's it, you're gone.
Yeah. She thought I was going to die that night.
Yeah.
So this is something that we had to work through and get through, but which we did.
And it's interesting because you've had a couple of brushes with doctors that have said pretty amazing things here that have knocked you for six. So Trev actually went into AF and had a reversion and ended up with cardiogenic shock and in the intensive care of Eye Hospital.
Yeah.
Now, I understand the doctor came around the next day and said to you, I didn't expect to see you here.
Yeah, I got out of bed
Yes.
because I was sick and tired of laying on the bed. So I got out of bed with all the pipes and everything coming out of me, and I sat on the chair, which I checked with the nurse, and she said, yeah, it's fine, Trev, And then the doctor come round and he sent all the rest of the people with him to the next cubicle. He said, I want to talk to Trev on his own. So he walked up to me, he said, what are you doing here, mate? And I said, I'll get back into bed, buddy. And he's going, no, he said, we lost you last night. I was going, oh, shit. And I just didn't know what to say to him. I was just, yeah, all right, sweet.
Yeah, so, again, you were told that you nearly died and that I gather you thought that you shouldn't be here. Now, that had a profound effect on you over the next 3 to 4 months.
3 months.
Yeah.
At least.
What happened?
Had a lot of trouble dealing with it. I was scared to sleep in my own bed of a night time. I was frightened I was going to die. So I got attached to the couch at home. And for some unknown reason, I got this little blue blanket at home. I became attached to it. It was like a security blanket to me. And it's weird, I'm 67 years old and I shouldn't become attached, but I did. And yeah, that got me through for the next 3 months. And then one night I said to Sue, I said, I'm coming to bed. She put a smile on her face. I said, nothing, enough for that, I said. And so, ever since then, it's been good. But in the same token, you've helped me a hell of a lot, psychologically and medically along the way. Like I've known this man for probably too long.
Yeah. People start talking.
Yeah.
Now, there was a period, again, 2 years ago where things got you lost a huge amount of weight. We couldn't quite figure what was going on. We knew it was your heart. And they ended up sending you to the Alfred and they said, that you may need a heart transplant.
Yeah.
I mean, that would have been a fairly big thing.
That was very hectic because they couldn't find a bed for me and we were going in there each day for 4 days running and doing all these tests. And it's just shocking in the end. And then they told me that I had to do something about my diabetes, and which I ended up going up to see them, and they put me on 75, whatever it is,
Insulin,
units or something, insulin, injecting me stomach 3 times a day. But then after that I picked up an infection. I was admitted to the Austin Hospital. They starved me for 4 days. I felt like chewing someone's arm off in the end. But it got rid of the diabetes. My blood levels have never gone above 6.4, I think, the highest blood level of a morning when I check now and again.
And it was interesting because Trevor suddenly deteriorated with his sugars from being around 6s and 7s up to 25s and 30s, and in the space of 3 months on no medication, as you can see, for diabetes, and his sugars are back to 6.2. So certainly something really changed. But you're managed now by multiple hospitals. So how do you, between the Alfred and the Austin, it must be pretty hectic, How many appointments do you have?
I got a lot of appointments, but it's worth it.
Yeah.
Like, this is my life. So I'll go through all the traffic and I'll go through all the crap, but when I had to have a colonoscopy over at the Austin and to get the doctor going there, I said, if I start smiling while I'm under, I'm enjoying it, keep going. So it's just, as I said, the attitude I've adopted, and I've had this attitude all my life, I think it's the correct attitude, and I think that's with a lot of patients, they just haven't got the right attitude. I hate people feeling sorry for themselves.
But, certainly, you must have good days and bad days.
Yeah, if you allow yourself to have a bad day, you will. But if I do something hectic in the morning or anything like that, and I'm really tired and sort of run out of breath and can hardly breathe, well, I'll go and sit down and relax, and I'll have something to eat and then just watch a bit of telly, and I come good. So then I can get back out there again. Because I told my wife I'm not going to become a cow's potato.
And this, you seem to have a great attitude. At times it must seem so hard when you have to put up with so many things. Depression must sneak in from time to time.
Possibility, but I'm always sort of laughing and making a joke of life. And if my missus starts carrying on, I say, I'm going to die, and then it shuts her up. So.
And the impact or the effect, on Sue, it must be hard for her on the sidelines, seeing you go through all this. How does she cope with it all?
It's just, I know she's a very special lady, I suppose. Probably got more patience than me. And she's the one who comes to the doctors with me and says, you got to do this and do that. And I say, yeah, sweet, no worries. Because I forget what they tell me what to do. So she's probably saved me.
Good thing. Now, his wife is in Queensland at the moment, so having a break from you, is that right?
Yeah, that'd be right, yeah.
So what's a good day for you then? If you had to say what a good day was, how does it...
A good day is up in the morning, have breakfast and all that. I might go out and mow the lawn, like the back one, and I say to myself, I'll do the front bit tomorrow. And, as long as you can sort of get on with life and not totally exhaust yourself, that's a good day for me. I don't worry about trying to work on Harley Davidsons anymore or anything like that. It's just out of my reach. So,
and a bad day, if you had to compare that to what a bad day looked like, what would a bad day be like?
Well, really, I don't think I've ever had a real bad day. Unless this has gone off and I've gone to hospital, it's a different story.
But that time when you were feeling, when you lost all that weight and we couldn't forget, you were struggling. It's interesting how you've forgotten just how bad you were.
Oh, yeah. I was in a bad way, but if you keep looking back on those times and dwelling on it, you're just going to bring yourself down further. So I don't like looking back and dwelling.
And so you still potter around and do occasional jobs for friends, is that right?
Yeah, build dog kennels and things like this, and
And so when people see you, you look so well.
Oh yeah. I get into a lot of arguments at shopping centres when I park in disabled parking. Oh boy, they hate me.
So how do you explain that?
There's too many ladies in the room now, so I can't really say how I explain it to them.
So, you've got a huge number of GPs and doctors watching this. If there was something that you wanted to tell them, what would you like to say to them?
Well, I've only come across one bad one, really, and that was that experience with my wife too. But you all show respect. I think that's the main thing. Once you get your patient on your side, he'll listen to you more, and it's just all a matter of respect, appreciating what he can do, because like yourself, I come to you and you say, listen, we better try this, and in the time you give me 2 tablets that I was allergic to, I broke out in a rash. Sorry, mate, but and we overcome that. I rang you up and said, throw them in the bin. And then we finally got on to something else, so it fixed everything, And that's why I have confidence in you, because you're always trying to do the right thing, and you're my key to life, so to speak.
And today, interestingly, I think you've discovered a new drug that you're going to try. Is that right?
Yeah, Aria? Yeah.
Arnie's.
Arnie, yeah, that's it.
So
I got it written down here anyway.
Yeah, what are you going to do with that note?
I'm going to take it home, treasure it.
And so you've got an appointment at the Alfred?
I've got an appointment on the 29th of this month at the Alfred, and I'll be saying, hey, look at this.
Anything else you'd like to say before we wind up?
No, that's about it. I'd like to thank you for having me today, and I've appreciated it.
And look, thank you very much for giving us those insights into heart failure. Thank you.
No problem.
Thanks very much, Ralph and Trevor. And I think a couple of points coming out of that. Again, as Trevor said, he's been with Ralph a long time. And as GPs, we do see the consistency. So there's appointments at the Alfred and the Austin. I'm starting to sound like a local, really, aren't I? But you go into all these different places, but the GP, as in our position, we tend to be the constant. Now, our next speaker is Associate Professor Nagesh Anavekar, who's a consultant cardiologist and echocardiologist and Director of Echocardiography, Senior Staff Cardiologist at Northern Health. He also holds both public and private hospital appointments at the Epworth, John Faulkner and Warringal hospitals. Professor Anavekar is going to talk to us about contemporary management of heart failure with some tips for GPs. Please welcome him.
Thanks, Joe, and it's a great pleasure to be here. The main focus of this talk is going to be on heart failure with reduced systolic function, although many of the concepts are applicable to heart failure with preserved systolic function. So we're here to talk about heart failure, people, and the stats that are being presented feel depressing. I mean, just consider this. Despite evidence-based therapies, the morbidity and mortality from heart failure is still high. Why is there a therapeutic gap for heart failure? Why? In order to address this question, we need a brief review of heart failure pathophysiology and pharmacology. We need to go back to the fundamentals, the basics. So, myocardial damage, regardless of etiology, be it myocardial infarction, myocarditis, cardiomyopathy, valvular dysfunction, results in the predictable activation of several neurohormonal pathways. The main ones which we are familiar with and which we target are the renin-angiotensin-aldosterone system and the sympathetic nervous system. Whenever there is compromised pump function in the context of chronically upregulated neuroendocrine pathways, this leads to cumulative toxic myocardial effects which perpetuates heart failure. So the mainstay of cardiovascular pharmacology that is related to heart failure has been, and generally continues to be, the blockade of these systems. Dating back to the mid-80s, the advent and the use of beta blockers, ACE inhibitors, angiotensin II receptor blockers, aldosterone antagonists has revolutionised the management of heart failure. There is no doubt we've come a long way compared to the days where heart failure was known as dropsy. However, these therapies, which are decades old, have reached an efficacy ceiling. And it's just arrogant presumption that blocking two symptoms can solve heart failure. We now realise and are aware that there are other players involved in this complicated syndrome. That is the therapeutic gap. So with that in mind, I'd like to introduce you to Terry. So Terry is a middle-aged gentleman with established moderate to severe chronic systolic heart failure. And despite him being on evidence-based conventional therapies, Terry continues to experience morbidity from his heart failure. He is complaining of worsening exertional dyspnea. He is complaining of markedly reduced exercise tolerance. Before we address his symptoms and his complaints, one should do a general screen for any precipitating factors. Examples of precipitating factors, and this is not an exhaustive list that you see on the screen there, include infection, anemia, arrhythmias such as atrial fibrillation, thyroid disease, renal disease. One should review any concomitant medications that could be exacerbating heart failure, such as non-steroidal anti-inflammatories, any negative inotropes or chronotropes, antiarrhythmics, some of the diabetic medications, and some psychotropes, to name a few. In addition, one may consider organising some investigations as part of their assessment, and this could include an ECG, again, looking for rhythm disturbances such as atrial fibrillation, conduction block. You may want to organise a chest X-ray, not only to assess for the features of heart failure and its complications, but for any infective causes, blood tests inclusive of full blood examination, iron studies, renal function, thyroid function, liver function, just to name a few. Let's assume with Terry that there is no active precipitant and he presents as a course of the natural history of his heart failure. So, apart from diuresing him to resolve his symptoms, possibly increasing his perinterval dose, is there anything else that can be offered to Terry pharmacologically to improve his clinical status and ventricular function? So I want you to hold on to that question, just dwell on it, and we'll come back to Terry in a moment. Another common feature and hallmark of heart failure is the presence of increased ventricular filling pressures. And this leads to atrial stretch and ventricular stretch. In response to chamber stretch, natriuretic peptides are released, and consider this as nature's way of decongesting the system via salt and water depletion, as well as having vasodilatory properties. So another management strategy in conjunction with conventional therapy would be to exploit these endogenous natriuretic peptides by blocking their degradation. Neprilysin is a key enzyme involved in the catabolism of natriuretic peptides. So with that in mind, I'd like to introduce you to Arnie. Not Arnold Schwarzenegger, who happens to be an idol of mine, but the concept of angiotensin receptor and neprilysin inhibition. The combination of sacubitril, which is a neprilysin inhibitor, with valsartan, which is an angiotensin II receptor blocker, forms the basis of an Arnie strategy. This provides the means of potentiating and promoting natriuresis while simultaneously blocking the harmful and deleterious effects of the renin-angiotensin-aldosterone system. So in one hit, we can favourably manipulate the yin-yang effects of heart failure. But does this concept work? Where's the evidence? Enter the Paradigm HF study. This was a landmark study published in September of 2014, the largest heart failure trial to date, having recruited 8,442 patients, all of whom had moderate to severe systolic heart failure. And this compared the Arnie strategy, that being the sacubitril-valsartan combination, to that of conventional therapy in the form of enalapril. It convincingly showed a 20% relative risk reduction for the primary composite endpoint in favour of the Arnie strategy. Now, this is a significant finding, given that the clinical pharmacology landscape for heart failure had not changed for several decades. So we can return back to Terry, and now we can further optimise his management with the use of an Arnie strategy. So in his case, we would cease his perindopril for 36 to 48 hours and introduce the sacubitril-valsartan combination in its place, with the view towards up-titrating to the maximum tolerated dose as quickly as possible. In patients such as Terry, hypotension, renal impairment and hyperkalemia can be problematic. In general, when encountering such issues, review any concomitant medications or therapies, and also be on the lookout and be vigilant for any other potential causes. In particular, be wary of these complications occurring in the elderly, those with renal disease, and those with low blood pressure issues. To conclude, the contemporary management of heart failure not only involves the blockade of the renin-angiotensin-aldosterone systems or the sympathetic nervous system, but now incorporates the potentiation of the natriuretic peptide system. And as this type of therapy is increasing in awareness, the heart failure guidelines have changed. The revised European Society of Cardiology heart failure guidelines now recommends that among individuals with moderate to severe systolic heart failure who continue to be symptomatic despite optimal use of an inhibitor of the renin-angiotensin system, that an Arnie strategy, that being angiotensin receptor neprilysin inhibition strategy, be considered. Thank you.
Excellent. Thank you, Nagesh. And I think to move to, in a moment, to our fourth speaker, we've sort of come from where we've been. We're looking at new treatments. We're now coming on stream, which leads nicely into our fourth talk, which is what does the future hold? And our fourth speaker is Dr. Leighton Kearney, who's a consultant and non-invasive cardiologist, undertaken postgraduate fellowships at the Austin and Royal Brompton Hospital in London. Currently has appointments at the Austin and Warringal Hospital in the public sector, and is the clinical services director for heart failure unit for Genesis Healthcare nationally, and is also in practice at Heart Care Victoria. Will you please welcome Leighton.
Thank you very much. So what does the future hold for heart failure? The face of heart failure is changing. We've got an ageing population. The risk factors for heart failure, hypertension, diabetes, renal disease, coronary artery disease are increasing. And as a result, the prevalence of heart failure increases with age, and so too does the complexity. We no longer manage heart failure in isolation together with its coronary artery disease or arrhythmia. We need to think about the impact of heart failure on the kidneys, on the COPD, on the patient's mobility, On the left there, you have a picture of what the changing face of heart failure looks like. Our patients are more informed. With the advent of smartphones, the internet, our patients will often come with their diagnosis or misdiagnosis in hand. But we can use this platform to help educate our patients and direct them to sites and websites and support groups that can help them in their management. So fortunately, there are a lot of medical advances in the pipeline. This decade is meant to be the decade of the stem cell. The stem cell can cure everything. Now, we're not there yet, but there are some promising signs. And a recent small study looked at umbilical cord blood and using stem cells from this to transfuse into patients with heart failure. And there was an improved left ventricular function and improved quality of life. Now, we need to take that further. We're not there yet, but there's promise. We heard from Nagesh. There are new drugs on the horizon. We have the ARNIs. But so too we have the sodium glucose cotransport inhibitors, better known as diabetic drugs, but actually showing great promise in the cardiovascular disease field and particularly for heart failure. And we have new ideas on old drugs and new transport delivery systems. Recently there's been developed, and it's in development in Europe, a subcutaneous format of furosemide, which is pH neutral so it doesn't irritate the skin. And it can be delivered through a patch transfer system on the body. What does this mean for us as medical practitioners? We may be able to institute an agent equivalent to intravenous furosemide to prevent hospitalisations, and it can be done in the home. We may be able to discharge patients earlier from hospital, and we know the longer the length of stay, the more they decondition. And we may be better able to look after our patients at the end stages of life, in the palliative phase, when they can no longer absorb their tablets or they're ineffective, to relieve their symptoms more effectively. But there's no point having medical advances if we just don't do the basics well. So we need to improve our own clinical practice. We have now looked at developing patient assessment tools that help us with those complex guidelines. We saw the numbers and it's very hard to track down on Nagesh's last slide there. What do we do and when? Important tools like this can be available on a computer, can tell us, your patient's not on a beta blocker, but you've told me they have heart failure with reduced ejection fraction. Why? And you can go through it. Okay, they've got asthma, that's okay. But if you don't have a contraindication, it brings up the quality of care. It reminds us that we need to be considering that for our patients. And similarly, for biventricular pacemakers, your patient is on optimal medical therapy. They have an ejection fraction less than 35% and a left bundle branch block. Why are they not on a cardiac resynchronization pacemaker? So these sorts of guidelines, tools can help us adhere to the guidelines and improve our overall practice. On the left-hand side of the screen, we have the Multidisciplinary Heart Failure Clinic. And this is a clear gold standard for management of heart failure patients, superior to a general clinical model. What this involves is a team-based approach with a cardiologist specialised in heart failure nurses, working in teamwork with a GP, working in teamwork with the local pharmacy and the rehab facilities to practice evidence-based medicine. These clinics often offer better access to care and nursing follow-up when changes to medications are made. We can individualise plans and focus on the psychosocial elements that we heard were so important. The education of the patient. The empowered patient is the patient that knows their disease well and is less likely to run into trouble. And they generally will have an outcomes focus, and this ensures that they stay at the forefront of care. So think of the local multidisciplinary heart failure clinics in your area and think of them as just as important as another drug. So we've talked about medicines and medical advances. We've talked about the clinical practice. Surely we are now in the age of technology, and this is where the greatest advances may come. Or should we call it the age of Big Brother? You can go down to the local electronics store and get any number of devices that can monitor your every move. They can monitor your sleep. They can monitor your heart rate. They can monitor the number of steps you make. They can monitor your blood pressure and your weight. And what's more, these devices can transfer wirelessly through to your smartphone or your computer. And potentially with advances in technology, they can transfer through to your doctor. So your doctor can keep an eye on the things that are going well, things that are going poorly. This is an example of an app that was developed here in Australia through the CSIRO. And this simple app, which asks patients to check their risk factors, what's your activity level, how many steps have you walked today, health matters, These things can be extrapolated to heart failure. What is your daily weight? How far can you walk before you get breathless? Are you having any trouble showering, dressing? Did you take your tablets today? And we can use that to empower the patient, but also to inform us and better utilise resources. And I'll come to that shortly. On the far end of the technology spectrum, we've got some really exciting advances. This, which is much smaller in real life, can be implanted into the distal pulmonary artery. It's batteryless and it enables wireless transmission to a receiver. And what does it give us? It gives us real data about the pulmonary artery pressures on a day-to-day basis. It can tell us the heart rate variations. And when this was studied in its major trial, it was used to guide medication changes. If the pressures went up, the doctors were alerted, they could increase the diuretics. When the pressures went down, you could reduce the diuretics, enabling fine-tuning from day to day, not month to month. And this resulted in striking improvements, 30% reductions in 6-month admission rates in patients with advanced heart failure. This goes further. We can now use pacemaker devices, defibrillator devices to remotely monitor our patients. They can tell us about their physical activity levels. The patient usually walks 4 hours. Over the last week, he's only been doing 1 to 2 hours. They can tell us about arrhythmias and heart rate control. They can tell us about pulmonary congestion through thoracic impedance, so we can detect when our patients are starting to tip over the curve. So this information can transfer to a local receiver through a service centre and be distributed to the cardiologist or the heart failure nurse or the nurse practitioner within your practice. And we can say, those 20 patients are doing well, a quick phone call will suffice. We don't need the routine review. Or we can say, those patients are doing poorly, we really should schedule them for a review. And this has the potential to overcome the greatest challenge to healthcare, and that is time. We would all have clinics, you have a sick patient and you add them on. With this remote monitoring, we can run virtual clinics. We can see the patients who need to be seen when they need to be seen, and allow the patients who are doing well to enjoy the quality of life of not having to spend their time in a doctor's room. So the final slide. This is the futuristic thoughts. So what is the future of heart failure? Or perhaps the future of medicine? Or the future of life? It relies on data. We need to change our habits of subjective data collection, writing the notes down. We need to change to objective data, because only with the gathering of more data can we learn. So if we've got a manual system within our rooms, we should change to at least record weights, blood pressures, symptoms in a quantitative manner. And from this, we can use the science of that data with reasoning and knowledge, clever computing, cognitive computing, and essentially artificial intelligence. And with that big data, we can answer the big questions. We may find the answer to heart failure with preserved ejection fraction. We may find the answer to this patient is at risk of admission in the next 3 to 4 days. It may be beyond the realms of our cognitive power, but with complex computer algorithms, we may find the big answers. So this is the future of heart failure, perhaps the future of our life. Thank you very much.
Thank you. Now, we're going to move across to panel Q&A. So we're going to set up the chairs and we'll be able to take questions from the floor. We've got a couple of roving mics, and also we have a couple of mic balls, and if you do in the middle and you get one of these tossed, if you want to ask a question, it's nice and soft, it's foam rubber, talk into the black part of the ball. So I'll toss that. There we go. As my kids tell me, Dad, you're just hopeless with anything to do with throwing a ball, and they're quite correct, but never mind, that's okay. So really, we've walked across a lot of issues from the past where there wasn't as much we could do about heart failure to the more recent present where we were doing as well as we could do, but we've sort of, as Nagesh said, we've sort of reached our ceiling. We've heard about how it impacts on the life of an individual with Trevor, and obviously Terry's case example of how his life was impacted as well. And we've had a bit of an eye into the future. And I think when you think about sort of smart technology and artificial intelligence, and you sort of think about the rise of the machines and Arnie, it's sort of there you go. All right, so look, we might take our first question off the Slido. And our first question, and look, I'm happy to direct this to anybody who's happy to take it. How do you manage potential hypotension when initiating new ACE, ARNIs or beta blockade?
Okay, so essentially, as stated in my talk, obviously you start at the lowest dose, and you'd have to be very vigilant with your patient. Particularly with ARNIs, there is this reluctance amongst in clinical practice, a fear that the ARNIs can make the hypotension worse. The data that we're getting out with the ARNIs is that you've got to be a bit careful, but you can push the envelope a little bit as long as you're monitoring the patient very judiciously in your rooms. As long as they're not symptomatically hypotensive, it is generally okay to try and keep pushing the dose up. I did make a very specific point about trying to up-titrate as quickly as possible. And the reason for that is, if you notice on the slide with the survival curves, most of the benefit happened in the first month. So that's why there's a push to try and up-titrate the ARNIs as quickly as possible. And this also generally agrees with inhibitors of the renin-angiotensin system. I don't know if Leighton has anything.
Yeah, I might sort of jump in there. Since I've been working with gout and with our heart failure project, certainly my tolerance for lower blood pressure has increased. So, I mean, what do you call a low blood pressure? Because I used to worry when people got to 110. He's happy at 95.
Yeah, absolutely, even 85. I mean, I go by the symptoms.
So I find that really interesting.
Yeah.
So if I can have someone sing with 90, but if they're fine, that's fine.
All right, happy to take a question from the floor. Anybody got any hands up who'd like to ask a question from the floor? Yep, over there. Gentleman in the red, talking to the black.
It's a follow-up to that. With that patient example you had, they were on amlodipine. Is there any reason you'd keep that especially, or would you drop that in favour of up-trading the ARNI if the blood pressure was low?
Yeah, I'd probably be in favour, if it's systolic heart failure, I'd be in favour of dropping the amlodipine in favour of the ARNI. Yeah.
All right, looking at our next question on the Slido, what's the role of BNP measurement in titrating to treatment effect and effect on prognosis? Who'd like to run with that?
Okay, so BNP measurement is a very effective diagnostic tool in patients who present with dyspnea, and it enables us to differentiate those that have dyspnea due to respiratory causes, those that have dyspnea due to heart failure. And the raw number itself is also prognostic. The data as to whether or not we can titrate to outcomes and improve the patient's final events is a little less clear. We certainly know that effective treatment does reduce the BNP, but whether or not we should be doing it on a regular basis is a little less clear in my mind. I'm not sure if...
I totally agree. The only thing that I'd add to that is that with an ARNI, your BNPs are going to go up because we're deliberately blocking neprilysin, so the BNPs will go up. So you can't, when using an ARNI, the BNP loses its effectiveness in terms of monitoring.
So you measure NT.
Yeah, NT, correct.
All right, happy to take another question from the floor. Please stick your hand up nice and high because it's difficult to sort of see looking into the light. Yep.
I'm sorry, I just want to know how often he's scanned and how often should he be scanned. And when you start him on Entresto, how often would you scan and what would you be looking for with regards to improvement of his ejection fraction?
Yeah, so I mean, I think you're not going to see acute changes. In the ECHO trials in heart failure, you'd need at least 3 months to see any objective improvement, and that too is very subtle. I'd give it at least 6 months before you'd see any objective changes. Do you have any comments on that, mate?
Yeah, so as a general rule, when initiating heart failure medication, it usually takes about 3 months to titrate, and I will generally, 3 months after hitting the maximal tolerated dose, repeat the echo to see what benefits we've got. But with the ARNIs in particular, the focus has really been on the outcomes and the clinical outcomes, and less focus on the echo ejection fraction. We know that's not the best predictor of outcome in the long term. So focus on the clinical benefits, and perhaps we'll get the left ventricular benefits as well along the way.
Right, moving back to the Slido, is there a role for initiating ARNIs post-acute hospitalisation for heart failure?
I mean, essentially, if the opportunity arises, you can start it post or during hospitalisation. It doesn't really make a difference. As long as there's clinical vigilance of, hypotension, renal impairment, those type of things. The setting, I don't think, makes that much of a difference.
I think...
For the GPs here, though, wouldn't we want our patients at least stable for at least some time before we initiate something like an ARNI?
True, absolutely. But again, whether it's in the hospital setting or in the outpatient setting, as long as you've got close vigilance and stability,
Yes.
then yes, it should be okay.
And as Nagesh mentioned, the data shows very clearly that within the first 30 days of initiation, we make a substantial difference to the risk of rehospitalisation, hospitalisation. So don't be afraid to start these agents earlier. They do have that extra natriuretic, diuretic effect that may be of benefit really early on in the management.
All right, we have another question from the floor. Yep.
I have quite a large nursing home population, all on the wrong side of 90 and thinking of their swollen legs and short of breath. And I realise all these clever things you're talking about, but my way of treating them is a bigger and smaller dose of Lasix, depending on how they're going. I realise that sort of turned the clock back 40 years, but that works for me, and the thought of them all going on to these places. Am I doing the wrong thing by doing it that way?
I think you have to look at quality of life. I mean, that's very important. I mean, for example, if you've got a patient such as like Trevor here, who's got a fantastic attitude, go-getter, you need to give him the full hog, okay? But for someone who's in a nursing home, bedridden, no quality of life, I don't think subjecting them to all of these type of therapies is of any value. I'd do exactly what you're doing. I don't know if any of the other panels would agree with that or disagree.
I think that's an excellent point. We really do need to individualise therapy, and if you've got somebody who's really very close to end of life, it is all about simplifying and improving quality of life. So we're really not then that concerned about increasing life expectancy as we might with a younger person. Say if it's fluid overload that's the problem, then that's what you deal with.
Back to the Slido, I might go to a low one. Should ARNIs replace ACE inhibitors in standard care? And maybe coupling with that, and we haven't got a lot of time to go into all the detail, but practical steps about switching to ARNIs, which often might involve ceasing other medications.
Sure. So let's go back to the end part of your question about switching or substituting. So if the patient's stable on an ACE inhibitor, then you need to stop the ACE inhibitor at least 36 hours before. And the reason is ACE inhibitors also block various vasoactive peptides that can cause angioedema, and neprilysin does the same thing. So back in the mid-90s, there was a trial called Overture. I don't know if you have heard of that trial with a drug called omapatrolat. The drug actually had good benefits, but it was ceased in terms of its development because there was a large incidence of angioedema because of that. So that's the reason why you've got to cease the ACE inhibitor and wash it out for at least 36 hours. With an ARB, that's not necessary because, as you can see in the combination, ARB is already in there. So if they're ARB tolerant, you can just do a complete switch. In terms of whether ARNIs would replace ACE inhibitors, that is the question. We don't know yet. The guidelines are not suggesting that at this stage, but the way things are going, I think that probably may be the standard of care. Because now we're not just focusing on blocking, but we're going to be focusing on blocking and potentiating endogenous factors as well. Any comments?
I was wondering if I could just draw the specialists out on something that I think is quite important, which I know you have alluded to a little bit, and that is differentiating between reduced ejection fraction and preserved ejection fraction, because there really are different beasts in terms of our impact of the impact of our therapy. I was just wondering if you would mind just expanding a little bit on that for the GPs.
So I think it's very important in the management of a heart failure patient to understand whether they are reduced or preserved ejection fraction, and we can only do that by imaging the heart with an echo or equivalent technology. And the real critical step is that reduced ejection fraction is the disease that has all the evidence-based therapy. Our ACE inhibitors, beta blockers, mineralocorticoid antagonists. For heart failure with preserved ejection fraction, it doesn't mean that we cannot improve their quality of life or perhaps their survival, but it's more the art of medicine rather than the science. So in that case, it's important to control their risk factors, their hypertension, their diabetes, their arrhythmias, and make sure that they're very well versed in the management of their fluid balance. So critical to try and, when you first see a patient with heart failure, define which group they fall into, and then we know whether we're trying to optimise those medications or whether we're really just managing the art and the risk factors behind it all.
Okay, we'll take another one from the Slido. Actually, you might jump down a little bit here. Where are we over here? So tiagrelor interferes with ATP, ADP metabolism and can mimic cardiac failure. Is there any treatment for breathlessness caused by this as a side effect to do with exercise?
As far as direct treatments, the treatment is to consider changing them to an alternative such as clopidogrel or prasugrel if appropriate. There's no agent-specific treatment for the breathlessness from ticagrelor, or as far as I'm aware. And it's very difficult to predict, but we are in the business of managing quality of life, and the small benefit of ticagrelor over the other potential agents might be overwhelmed by the side effects. So be aware that it is okay to change in that context.
Excellent. Questions from the floor? Yes, gentleman there.
Where does diastolic dysfunction feature in your cardiac heart failure spectrum?
So diastolic dysfunction is still, it's unlike systolic heart failure, where we've got a lot of trials and a lot of evidence in terms of therapies, diastolic dysfunction has still been quite nebulous. All the drugs that we use for systolic heart failure have not really been successful in diastolic heart failure. So as Leighton said, it is a different kind of a beast, and it could just be more addressing the risk factors rather than the underlying process itself. Diastolic dysfunction is important. It's going to be an increasing problem given the ageing population and the increasing prevalence of risk factors. But I think the current consensus at the moment is, as Leighton said, more addressing the diabetes, the hypertension that causes the diastolic dysfunction. It'll be interesting to see Paragon's, the latest study that we're looking at in Tresto, or the ARNIs in diastolic heart failure. It'll be interesting to see what that shows. But up until now, apart from addressing risk factors, there's no real major blockbuster way of treating with diastolic dysfunction. It's more fluid management and addressing risk factors.
I might just add on there. I think one of the issues with heart failure preserved ejection fraction is it's actually about 10 different diseases. It might be hypertensive heart disease, it may be arrhithmia, it may be valvular heart disease. So it's very difficult to recruit to trials and get a similar population group. So hopefully maybe that's the artificial intelligence that can help us there.
So just in terms of the nomenclature, so that we can avoid some confusion, so that we used to talk about systolic and diastolic, which I think has largely been replaced by preserved versus reduced ejection fraction. So would it be fair to say that when we would talk about diastolic heart failure, we're really talking about what we would now call preserved ejection fraction, as opposed to diastolic and systolic? It's preserved versus reduced ejection fraction.
Absolutely. Part of the problems with the old nomenclature of the systolic versus diastolic was, even in the diastolic heart failure trials, they actually use ejection fractions of 45% and above, which is still systolic failure. So that's why this new nomenclature of preserved ejection fraction versus reduced ejection fraction, I think it's a bit more finer and more refined. But yeah, the previous nomenclature did cause a lot of confusion.
Diastolic function is actually an active process as well. We used to think it was a passive relaxive process, but it's actually still involving active contraction of some cells. So it is a systolic sort of process in itself. So that's why it became a bit more confused.
And I guess the other thing is just to add that you can't isolate the two. Systolic function, diastolic function, they're all connected. So every patient with systolic heart failure is going to have diastolic dysfunction. It's part of the whole spectrum.
All right, moving back to the Slido. My understanding there's little evidence of survival benefit from ARBs combined with ACEs. Has this changed?
So essentially, the Valiant study, which looked at this heart failure post-MI, so that looked at captopril versus valsartan versus the combination of captopril and valsartan. And what it showed was that the survival curves are all on top of each other. So what the information we gleaned from that was, the survival benefit was the same as an ACE inhibitor or an ARB alone. You didn't get any further benefit by completely blocking the renin-angiotensin system. So that was a lesson we learned from that. And the other lesson we learned from that was that if you did block the system completely, you started running into problems of renal dysfunction, hypotension, hyperkalemia. So our rigor for blocking things, I think it's telling us, nature's telling us, you can't block systems completely. We need part of the systems to keep things going.
Question from the floor. Are there any hands up? Yes, in there.
Just trying to help Trevor's health. I noticed on just the medication up there, he was on eplerenone 25 milligrams and Inspirate 25 milligrams, both the same medication. So has anyone checked his medication recently?
Must have been one of those I forgot to throw out. Probably just a typo because I was typing them in pretty quickly. But yeah, he's not on two separate at that dose, so we've got that right. But interestingly, did anyone pick up on his list of medication what was missing?
Arnie.
Yeah, so he's not on an ARNI. So that's one of the things that we were talking about at the very end about going back to his cardiologist and saying, should I be on this?
I think that's a really important point overall for pharmacological care. About 25% of hospitalisations could be prevented and may be related to adverse pharmacological interactions or inappropriate use of the prescribed medications, or the patient not being on what we think they're on. So it's really important when a patient turns up to see you in your practice to get them to bring their medications in that they're actually taking. Advise them to take along when they do see their specialist as well, because it can be very confusing and actually it can cause harm if we try and change things that are not exactly as we thought.
Yeah, absolutely. We just like talking about the big data before late, and that's sort of like mini data, but so critical and important. Look, this is an interesting question. We should always be questioning of what we're doing. We're supporting ARNIs on the basis of one study. Why?
That study, as mentioned, is the largest heart failure trial to date. There are small supporting studies that have supported the concept of ARNI, but you've got to also remember getting these trials up is very difficult. And we have to rely on pharma to do these studies. It is very difficult to get such multi-centre studies up. So currently, this study being so large and which is powered to detect this difference and convincingly showed, 20% relative risk reduction of drug versus drug is very hard. It's hard as it is for drug against placebo, but this is drug against drug. So already the bar has been set quite high. So based on that, this study does give us convincing evidence to initiate ARNIs as part of management.
And I think fair to say it was a very well thought out, well designed trial.
Correct.
So it's not one of those that you think, this was really well designed.
Correct.
Question from the floor. Yeah, wait at the front here. Just wait for the mic.
The patients with the pure preserved ejection fraction, do they get a raised natriuretic peptide?
Yes, they certainly do. So the natriuretic peptides are in response to cardiac filling pressures. And in fact, preserved ejection fraction is a problem of raised cardiac filling pressures. So it will go up. The levels of increase may be different depending on the degree of systolic heart failure we compare to, but they certainly do get raised BNPs and NT BNPs.
So they should respond to an ARNI, should they?
There's currently a study ongoing, which both Nagesh and I have participated in, to try and answer that question.
All right. What is the number needed to treat for regular, appropriate physical exercise? It's a fairly difficult question.
I can kick the ball going because those people who attended the heart failure program or the ALM would have said that we actually talked about a trial that was done about 5-6 years ago in Italy where over a 10-year period, those people with heart failure who attended an exercise program had a 50% relative reduction in death. So now I don't know the exact number needed to treat, but it was a fairly, it had a huge impact. So do you need the number needed to treat? I wouldn't know.
I'm not sure, to be honest.
Trevor, did you participate in cardiac rehab along the line?
I've tried it, but every time they do it, they seem to push it too much. Yeah. And my body just can't take it. Like I used to be really fit, but you just can't, you can't keep up with them. They think you're a Superman in the end. So, you just want to throw rocks at them.
Which is another form of exercise.
Yeah. But having said that, you still potter it, you still do your
I still do my own
mowing.
exercise. Yeah, I've got a gym set up at home and the treadmill and all that. And I do that when I feel like it.
Yep.
So you've got to keep active.
Yeah. All right, questions from the floor. Have we got anything on this other side? No? Any more questions from the floor at the moment? If not, we'll take another one from the Slido. Where are we? Any guidance, recommendations on what should be included in the GP chronic disease management plan for a patient with chronic heart failure? Maybe Gary or Ralph want to pick up with that one.
Well, again, those people who attended the ALM today, the very last session was all about developing, an appropriate care plan. And they'll know that I'm really passionate about the annual GP care plan, team care arrangement with 3 monthly reviews. And it's the reviews where you get the evidence of a good outcome. So And then the way we go about doing it's really important. So one of the things we did talk about, that it's about engaging with the patient. So it's not a pre-populated sort of thing. It's about working out where that person is at this time, and what is it that we need to do. So we talked about if they're decompensating, well, the acute phase is getting them dry and stable. But if you've got them over that, then it's talking about titration of medication. But then talking to the patient about things like fluid restriction, salt restriction, and so on, and getting them on board to involve them in the whole process. And we did a lot of talk about motivational interviewing. So the guidance is speak to the patient, get their view on things, involve them in what you're trying to achieve. Don't try and achieve too many things all at once. That'd be fair enough, wouldn't it? Yeah. So I try to stick to 3 goals at a time. And a lot of people say that's even too much. But I think 3 goals to work with is a good way. How do you do it, Gary?
Yes, I agree. So I think the whole idea of a GP management plan is that we don't do this piecemeal episodic management or crisis management. So it's really an opportunity to step back and say, what's the overall comprehensive plan for this person? And I think the question about the cardiac rehab or lifestyle modification is really a very good one, because the foundation of any chronic disease, heart disease, diabetes, obesity, you name it, whatever it is, lifestyle modification is the bedrock of that. And the evidence for it is good. It is good among many conditions. And then you build on top of that. So I think you can really have a very similar approach for pretty much just about every one of your chronic conditions. You look at optimising lifestyle, you then look at optimising medication, and then you look at, as Ralph says, the individualising the other things. Is there psychological distress? We need to address that. Are there unique things about this individual that require something specific to them? So I don't think it's really difficult, and I think if we have a very similar approach to all of our chronic disease management plans, you can actually get it automated fairly well. And what I mean by that is not necessarily hitting the template, but having the thought process automated, that you go through, your foundation of lifestyle, pharmacotherapy, and then the add-ons on top of that.
But just before, you've got to be talking about a pet subject now, but certainly, things about self-management I think are really important. So there are certain things that are very specific to heart failure, like the daily weighs. If someone puts on more than 2 kilos over 2 days, they have to increase their diuretic, or they must come and see you into the clinic. It's those sorts of snippets that we can get patients to do that can actually avert a hospital presentation. So we need to also incorporate those sort of activities within the care plan.
All right. We'll take another one for the Slido. I'm happy to take one from the floor if we have any. No? All right. Now, I think we've sort of touched on how can cardiac rehab assist patients with heart failure. I don't know if anybody's got anything they want to add on to that, or I think we've probably covered.
I'm just going to add that with rehab, there has been emphasis, correct me if I'm wrong, of doing, and you can tell us with your experience, a lot of cardio in the rehab.
Yeah.
There's now data coming out from North America that that's probably not the way to go in terms of rehab, and more strength training is important, because there is an interaction between skeletal muscle and the heart. And so possibly why you're having a negative experience is because they're pushing more cardio on you, more treadmill and that type of stuff. Yeah. Whereas you probably benefit more by doing a bit of weights. And it's definitely been shown that there is, in Canada and North America, that's where they're moving towards more strength training rather than more cardio. I don't know if you...
Yeah, I think my reading of it is a combination, but certainly recognising the importance of resistance training. As a key feature.
I agree with what you were saying, because when I'm doing weights at home, I can judge me breathing and all that, but if I'm on a treadmill, I just can't do it. Yeah. And when you're in a training facility, they tell you, I try and do 10 minutes more. And you think, I just can't do it.
Just Arnie getting you to that one more rep. How do you, this, I suspect it's not going to occur that commonly, but how can you manage pregnancy in a person with heart failure?
Gee, that's been a big theme today. But I'm not...
Pregnancy?
Yeah, so people getting cardiomyopathy.
Be my partner, you won't get pregnant, I'm telling you.
I think there are specialised centres and they should be managed by a cardiologist expert in pregnancy in consultation with a high-risk obstetric service.
Yeah, no, I'm not sure we can go much further than that. I think we've also touched on the practical switching. We've dealt with that one. Beta blockers are given for cardiac failure. How common is bronchospasm with these beta blockers, and what's the best treatment options?
Yeah, I think I don't think it's that common, to be honest, anecdotally anyway. If you do come across bronchospasm, there is the option to use nebivolol, which is a highly specific beta-1 receptor antagonist. To give you some numbers, metoprolol is about, I think, 25 times beta-1 specific. Nebivolol is 1,000 times beta-1 specific. So generally speaking, if I do encounter a patient who has bronchospasm, then I switch them to nebivolol, and I haven't encountered any major issues. Have you had any issues with that in practice?
Okay, so I think certainly just from an anecdotal point of view,
Yeah.
it's not been a challenge.
Yeah.
I think also there's been this lingering idea that beta blockers in COPD are contraindicated. The evidence is very, very clear that beta blockers in COPD actually improve survival.
Correct.
I agree. And in practice, from our own work, we know that we can achieve beta blocker usage of around 90%. So maybe it's an issue for a broad range of reasons in about 5 to 10% of patients, whether that be blood pressure or bronchospasm.
All right, happy to take another question from the audience if we have one. No? Okay, hang on, we just work out. So our next one here. This is specifically to Professor Anavaker, but I'm sure anybody can pick it up. Does the ARNI strategy apply to patients with AF? If so, do you start before or after digitalis?
Yeah, so essentially it does apply. So when they did the sub-analyses of the different subgroups, AF, diabetes and stuff, you still showed a benefit. If they're on digitalis beforehand, that can still continue. It doesn't make a difference. But yeah, there's definitely a benefit in that subgroup as well.
I think it's really important to note there that digoxin is not a prognostic medication in heart failure. So you would certainly, if they were not on digoxin, you would go to the ARNI strategy first, as the increment is for mortality benefit, rather than perhaps some quality of life markers alone.
Where do ARNIs fit versus MRAs in the guidelines?
So essentially, if they're already on an MRA, you'd still continue with the MRA. If they're not on an MRA, and they've still got moderate to severe systolic dysfunction, then you haven't actually optimally used an inhibitor of the renin-angiotensin-aldosterone system. So you should do the MRA first, and then consider an ARNI after that, if that doesn't work.
All right, well, I think that's answered that question. Should you use MRAs before ARNIs? So that's excellent. 2 birds with 1 stone. We've done the practical steps. What about heart failure with preserved ejection? Oops, sorry, let's just move before my eyes.
Yeah, we have one in the audience. Yep.
Oh, sorry, yeah.
I just had a quick question about echoes. It seems that a lot of the imaging places are now offering echocardiograms. Is there any way you can judge what's a good service? Is there a lot of difference between, what's being offered should you go through the cardiologist?
Either Nagesh or myself service are fantastic.
So refer to them.
And this is my number,
A very important question, and there is a high range of quality out there. It's very difficult for me to say how to define that. I think it's important to look at the quality of the report. Does it make sense? The numbers match? Are there differences within the body of the report compared to the conclusions? Just for a marker of, is this person really paying attention when they're reporting? But I think personally you'll get to know the services and whether you trust their services. And if you can actually build up a relationship with a doctor that you know is reporting, so if you've got a result you can call them, I think that's probably the biggest sort of advantage. So if you can work with a service where you know that cardiologist also consults in your area, I think that can probably be the biggest way to benefit your patients.
Which leads us maybe to the last question. Should all patients have the echo early?
So, I think one of the most important things, again, we were talking the ALM that we're doing on heart failure, that if we can actually get people much earlier before they start to go down that slippery slope, we're going to have a much, much bigger impact. So certainly one of the things that we were talking about is identifying those people at high risk. So, your older person, past history of an AMI, you should be thinking about, does this person need to have an echo? And if you pick up that dysfunction early, treat it aggressively. What do you guys think?
I totally agree. Absolutely.
Can I just expand on that? This is not just with heart failure, but if you step back and think about how we manage other conditions. So you're not going to diagnose or treat diabetes without getting at least one, probably several blood sugar readings. You're not going to treat their hypertension without getting serial blood pressure measurements or 24-hour ambulatory blood pressure or home blood pressure monitoring. And yet we somehow think it's okay to treat heart failure on the basis of symptoms alone, or diagnose COPD without spirometry. So I think we need to step back and always ask, do we have objective support for our clinical appraisal? And that then will guide your treatment more effectively and accurately.
All right, look, on that note, I think we will stop, and I would ask you to thank all our speakers, Leighton Kearney, Professor Nagesh Anaveka, Trevor Duncan, Ralph Autumn and Gary Killob. Thank you to everybody, both online and here, for your attendance and your participation. Thanks to Novartis for supporting the event, and enjoy the rest of your evening.